Hello, my name is Ash McLaren. I'm a senior here at the University of Oregon, and my research was conducted in the Orchids Lab under Dr. Sheila Crowell and her graduate student Nico Molina here in the UO's Psychology Department. My research is titled The Protective Function of Resilience on Maternal Childhood Trauma and Infant Emotion Dysregulation. This study explores how a pregnant person's childhood trauma may affect their infant's ability to regulate their own emotions at 7 months postpartum, and whether a pregnant person's resilience might serve as a protective buffer within that association. The three core variables explored in this research are maternal adverse childhood experiences, or ACEs, maternal resilience, and infant emotion regulation. Adverse childhood experiences are defined as challenges endured early in life at any point between birth and the age of 18. These can include psychological, physical, and sexual abuse, as well as household exposures to substance abuse, mental illness, domestic abuse, divorce, and criminal behavior. Resilience in this context refers to a person's capacity to adapt to adversity. It includes traits like self-esteem, self-efficacy, perseverance, and other intrinsic skills that support coping and recovery during hardship. Finally, infant emotion regulation is the infant's ability to manage and respond to their emotions and external environment. When an infant shows rapid emotional shifts or reactions that seem disproportionate to the situation, this is referred to as emotional dysregulation. Maternal mental health during pregnancy plays a vital role in promoting healthy outcomes for both parent and baby. Pregnancy is a uniquely vulnerable time, with heightened risk for mental health challenges such as stress, anxiety, and depression. These difficulties are linked to a number of negative outcomes for the fetus, including preterm birth, low birth weight, and behavioral challenges early in life. A growing body of research has identified that individuals with a history of adverse childhood experiences, or ACEs, are at increased risk for experiencing mental health problems during pregnancy, which can heighten distress during the perinatal period, further increasing risk for poor outcomes in both mother and child. Research shows that maternal childhood adversity can influence infant development even beyond birth outcomes. Specifically, maternal ACEs have been linked to differences in infant emotion regulation, or the ability to manage and respond to emotions and environmental stressors. However, not all individuals with a history of ACEs experience poor outcomes, as resilience has been shown to buffer the impact of ACEs on long-term physical and mental health. Studies suggest that resilience during pregnancy is associated with reduced risk for depression, anxiety, stress, and PTSD. For pregnant individuals with high ACE exposure, resilience may act as a protective factor, reducing the likelihood of adverse outcomes for both mother and baby. Despite this promising research, few studies have explored whether resilience can protect against infant outcomes specifically, such as emotion dysregulation. Our study seeks to fill the gap by examining whether maternal resilience moderates the relationship between maternal ACEs and infant emotion dysregulation at 7 months of age. Grounded in resiliency theory, we conceptualize this study through the lens of risk, protective factors, and outcomes. ACEs represents the risk factor, maternal resilience serves as the protective factor, and infant emotion dysregulation is the outcome of interest. Ultimately, we aim to identify modifiable, strength-based targets, like resilience, that can inform future interventions and help disrupt the cycle of intergenerational trauma. My research utilized data from the Baby Affect and Behavior Study, a 3-year longitudinal prospective study that sought to explore the intergenerational transmission of emotion dysregulation. Participants were recruited through online surveys and through local women's health clinics at the 3rd trimester and were studied at different time points up until 36 months postpartum. Although this study included a multitude of time points, as well as a large barrage of measures, this research focuses primarily on T1, the 3rd trimester, and T3, 7 months postpartum. Measures gathered at T1 include 10 items from the Traumatic Experiences of Betrayal Across the Lifespan measure that assessed for maternal adverse childhood experiences, as well as the Connor-Davidson Resilience Scale that measured for maternal resilience. At T3, infant emotion regulation was assessed by using the Infant Behavior Questionnaire. Our sample included 223 pregnant participants and their infants, with ages ranging from 19 to 39, with an average age of about 30. 222 of our participants identified as female and 1 as non-binary. Data analysis was conducted using a subsample of the 123 participants who completed all 3 of the measures relevant to my research questions. Our first hypothesis predicted higher maternal ACEs would be associated with greater infant emotion dysregulation. We tested this using a linear regression model. However, the association was not statistically significant, indicating that, in this sample, maternal childhood trauma did not predict poor infant emotion regulation at 7 months postpartum. Our second hypothesis proposed that maternal resilience would moderate this association, potentially buffering the effects of maternal ACEs on infant emotion dysregulation. This interaction was also non-significant. While neither hypothesis was supported, these findings still offer important contributions to the literature. Based on these results, we are able to observe that maternal adverse childhood experiences do not significantly impact her infant's ability to self-regulate at 7 months postpartum. Several factors may have influenced these findings. First, it's important to consider that emotion regulation is still rapidly developing at 7 months. The effects of maternal ACEs may emerge more clearly at later stages of infancy or early childhood, when emotional and behavioral patterns are more stable and observable. Second, while resilience is a key protective factor in our framework, it is multidimensional. Social support is considered a critical component of resilience. However, the Connor-Davidson Resilience Scale primarily captures individual traits and does not assess social or contextual dimensions. This may have limited the measure's alignment with the full scope of resiliency theory. These null results emphasize the importance of replication and the need for longitudinal studies that continue to examine how early adversity and resilience shape development over time. They also encourage us to consider other moderating factors, such as parenting behavior, social support, and biological stress markers. In conclusion, although our hypotheses were not supported, this study contributes to the growing body of research on intergenerational trauma, resilience, and early socio-emotional development. In the future, I hope to see research that continues to build on this work, so we can better understand how to support families, promote resilience, and ensure the best possible outcomes for the next generation. I'd like to thank my mentors, Dr. Sheila Crowell and Nico Molina, as well as the Orchids Lab for their invaluable guidance. I also want to thank Dr. Christabel Dragoo, Denise Elder, and my McNair Scholars cohort for their encouragement throughout this process. And finally, thank you for taking the time to listen to my presentation.